All right, so we are moving now to a very dedicated clinician, Scott Schuetze, from the state up north. And I can say that, Dr. Schuetze, because I'm born and raised in Columbus, Ohio. So you know it's hard for me to say University of Michigan. But today I am so proud of the University of Michigan and the work you're doing. So Dr. Schuetze is going to present some preliminary observations from a phase 2 trial of Trametinib in patients with EHE. So welcome, Dr. Schuetze.
Well, thank you very much for inviting me. I'm actually honored to present at this wonderful 360 conference, and I attended last week as well, and the presentations have all been really excellent, and it's just terrific to see so many people coming together around this very rare disease. And so what I thought I would do was really to give you a sneak peek, so to speak, of a phase 2 clinical trial, a prospective clinical study that we've performed in patients with unresectable or metastatic EHE. And this study was supported by the NCI as well as our clinical research collaborative group, SARC. So I don't need to really give you a background on EHE, but suffice it to say that we know it's a malignant vascular cancer, and there's really no defined best standard therapy when the cancer cannot be managed surgically. We also know that the disease course can vary greatly from being extremely indolent and growing very, very slowly over many years in some patients to a much more rapid, aggressive growth rate in some patients. We have some data, very limited, on the effects of drug treatments in patients with advanced EHE. One retrospective study of chemotherapy in 42 patients reported no objective responses from the chemotherapy with a median progression-free survival of about 5 months. A phase 2 trial of bevacizumab or Avastin in patients with vascular sarcomas enrolled 7 patients with EHE, and in this cohort there were 2 partial responses with a median progression-free survival of about 10 months. And a phase 2 trial of sorafenib conducted in Europe reported 2 partial responses among 15 patients that were enrolled and treated with a median progression-free survival of 6 months. We also know from work done by Brian Rubin, among others, over the past 10 years that the large majority of EHE harbor translocation between the TAS or WWTR1 and the CAMPTA1 genes, which creates a fusion transcription factor that seems to increase the expression of connective tissue growth factor that can feed back on the EHE cell and stimulate growth and metastasis through the MAP kinase pathway. Trametinib, which is the generic name, also known as Mekinist, the brand name, interferes with this MAP kinase pathway by blocking activity of the MEK kinase. And at the time that we designed this trial, Trametinib was available for investigational or experimental use through the National Cancer Institute's Experimental Therapeutics Clinical Trials Network. So our hypothesis, based on a lot of preclinical data that was done, as well as a single patient who was enrolled on a phase 1 study of Trametinib, was that treatment of patients with EHE using Trametinib would stop or slow the growth of EHE and hopefully result in some objective tumor responses. The patients with EHE control from Trametinib would have improvement in cancer-related pain and their quality of life. And we also hypothesized that some biomarkers could help us to figure out which patients had more aggressive cases of EHE. If there are elevated markers of inflammation, such as the erythrocyte sedimentation rate or C-reactive protein, as well as connective tissue growth factor, these patients might have a more aggressive clinical course. And that Trametinib blocking the MAP kinase pathway could affect the levels of connective tissue growth factor. Frankly, we don't really know if those levels are going to go up or go down on treatment with Trametinib. This trial required a lot of support, and as they say, it takes a village. The NCI Experimental Therapeutics Clinical Trials Network provided Trametinib through a agreement they had with Novartis. They also provided funding to clinical sites for the research activity. SARC provided support through patient screening, coordination, and clinical site support. They also were very instrumental in providing logistical tracking for biospecimens, pathology, and the questionnaires. The EHE Rare Cancer Charity provided financial support for optional tumor biopsies, and the EHE Foundation provided a lot of support for patients with connection to clinical trial sites and referrals. The study was supported by the NCI Imaging and Radiology Corps, which is providing storage of digital CT and MRI images that are collected from patients on the study. The Biopathology Center is providing storage of biosamples. Medidata is where the clinical trial database lives, and Theradex is providing clinical trial monitoring. There are many investigators involved in this trial. Dr. Brian Rubin, of course, is instrumental. He is providing the pathology review and is instrumental in helping to oversee analysis of the samples at the Cleveland Clinic Fish Lab. He's also going to be performing the correlative research studies. I oversaw the trial as the principal investigator. Dr. Lauren Schwartz at Columbia will be analyzing the CT and MRI images. Dr. Carla Ballman at Weill Cornell Medical College is the study biostatistician. Of course, there are many participating site principal and site investigators, and Dr. Helen Chen is overseeing the Trametinib therapy portfolio of studies at the NCI. Our primary objective for this trial was to estimate the objective response rate using RECIST 1.1. Important secondary objectives were to estimate the 6-month and median progression-free survival rates, the 2-year and median overall survival rates, the safety of Trametinib, and importantly to evaluate patient-reported symptoms using PROMIS questionnaires, which are validated questionnaires with a focus on patient pain and their quality of life. Some exploratory objectives are to compare the rates of EHE progression on treatment, to evaluate the effect of Trametinib on tumor volume, the effect of Trametinib on markers of inflammation, and the effect of Trametinib on levels of connective tissue growth factor in the blood. We designed a trial to be what we call a single-arm, open-label, phase 2 clinical trial. Everybody who enrolled on the trial received Trametinib, 2 milligrams taken daily, initially with options for dose reduction if adverse events were experienced. Tumor tissue was submitted after patient enrollment for review by Dr. Rubin and for the FISH, the fluorescence in situ hybridization test to look for the TAS-CAMPTA1 translocation. Safety assessments were done about monthly. We required submission of CT and MRI digital images for central review, biosample collection for correlative studies, and there were optional tumor biopsies to evaluate the effect of Trametinib on EHE biology. In order to accomplish our goals, we set the objective response rate at 20%, which would be a potential indication that Trametinib was active in treating patients with EHE. This required 4 or more objective responses in order to meet this goal. If we saw fewer than 5% objective responses, we would essentially determine or assess that Trametinib had no activity in the treatment of EHE. In order to accomplish this, we designed a 2-stage enrollment. In stage 1, we plan to enroll 13 patients with evaluable disease. If there were no objective responses seen in the first 13 patients, then we would stop the trial for futility. If we saw at least 1 objective tumor response, then we would open up to stage 2 and enroll 14 more patients for a total of 27 patients with evaluable disease for the objective response. Partway into the study, it became clear that the rate of tumor samples in which we were able to document the presence of TAS-CAMPTA1 fusion were actually much lower than we initially anticipated. And in 4 of the first 13 subjects who enrolled, we were unable to confirm the presence of the TAS-CAMPTA1 fusion for a number of reasons. And so because of this, we amended the study to continue enrollment until we had enrolled a total of 27 patients with TAS-CAMPTA1. And we had anticipated that the enrollment rate would be about 1 patient per month. Some of the key eligibility criteria were patients had to have metastatic or unresectable EHE, measurable disease. They had, importantly, needed to have evidence of objective disease progression prior to enrollment, or cancer-related pain requiring narcotics for management. So we really wanted to enroll patients who had the more aggressive versions of EHE, and really not enroll the patients who had very indolent disease that was asymptomatic and not interfering with their normal activities. We allowed enrollment of children 15 years of age or older. Tumor had to be available for evaluation of the TAS-CAMTA-1 FISH testing, and there needed to be acceptable organ function and no contraindication to taking Trametinib. As I mentioned, Trametinib was taken daily in 28-day cycles. We obtained blood work for safety assessments. There was eye exams that were needed prior to treatment to make sure there were no contraindications, as well as cardiac evaluations every 12 weeks. We assessed tumor response every 8 weeks for 24 weeks and then every 12 weeks. And the quality of life questionnaires were completed prior to starting drug treatment, after 4 weeks, and then after tumor response and or progression of disease. We also collected blood for biomarkers. The trial was actually opened at 36 academic medical centers that participated in the NCI Experimental Therapeutics Clinical Trials Network, and study participants enrolled in 16 different centers. The centers that enrolled patients are shown on this slide, and the number of patients enrolled in the different centers are shown as well. This is a graph of the rate of the cumulative enrollment, sort of the rate of accrual. In the green bars, it shows the number of sites that opened the clinical trial, and there was a pretty quick uptake in the sites opening the trial. The blue line represents the actual enrollment, and as soon as we opened up the trial at a number of sites, you could see a pretty brisk uptick in the enrollment. There's a plateau at 14, where we were waiting to see if we were going to have an objective response in the first cohort. We did see an objective response, and so therefore we opened up enrollment to the second cohort, which you can then see a pretty steep rise. This sort of late plateau right here is us really trying to fill 1 or 2 final slots with patients who have tumor in which we're able to document the TAS-CAMTA-1 translocation. So getting down to some of the data from the study, so far we've enrolled 43 patients on the study. The median age is a little bit older than what is typically reported for EHE, with a median age of 54, although the range is pretty broad from 22 to 81. Of interest, 11 patients enrolled were over age 65 years, and even though we'd opened the study for enrollment of children age 15 or older, there were no children enrolled on this study. 2/3 of the patients enrolled were women, most were white, and most had a pretty good performance status, either an ECOG performance status of 0 or 17, or 17 with an ECOG of 1. This table shows you the location of the EHE amongst the patients who enrolled. 23 patients had lung predominant disease, 14 liver predominant, 3 the predominant disease was in the soft tissue, 2 was within the abdomen, and 1 patient it was in bone. These are the results of the FISH testing. We're looking for a total of 27 patients enrolled in which we're able to detect the TAS-CAMTA-1 fusion. We've been able to detect that in 26 cases. In 7 cases, we were not able to detect the presence of the translocation by FISH. In 3 cases, the test failed as more of a technical issue, probably insufficient tumor, than the fact that the translocation may not be present. In 3 cases, there was insufficient tumor tissue in the tissue that was submitted by the enrolling site in order to conduct the FISH test. In 4 cases, tissue was not submitted. Now, these are just some very preliminary data on some of the biomarkers we're looking at. In 26 cases, the C-reactive protein level was high in the patient at baseline prior to enrollment or prior to starting treatment. In 14 cases, it was normal. We're going to be taking a closer look at this to see if it correlates all with outcome. And we're still in the process of looking through and sort of collating the data on erythrocyte sedimentation rates. And this is the table that sort of outlines the status of patients. 43 patients enrolled, 41 patients started drug therapy, 2 decided not to start drug therapy after enrolling. 6 of the patients withdrew after starting therapy. 6 patients unfortunately died while on treatment from progression or complications of progression of EHE. 3 withdrew because of adverse event. 25 stopped therapy because of disease progression, and 1 remains on treatment. This is a preliminary sort of look at the adverse events that patients experienced. Many patients experienced a rash, fatigue, nausea, diarrhea. We think that in the majority of these cases, it was related to the the Trametinib treatment and not to the EHE. A number of patients experienced alopecia, and some patients they decided to stop treatment because of the alopecia or hair loss. We saw a few patients who had problems with anemia and decreased albumin. There were some liver abnormalities that were noted as well. As far as serious adverse events, those or significant adverse events, I should say, those that are considered grade 3 or severe or higher, these are the adverse events that we're seeing at anemia, dyspnea or shortness of breath, low oxygen levels, respiratory failure, low blood pressure, and rash. This is some early data on the responses that we're seeing. There were 3 partial responses that have been reported so far. 28 of the patients had stable disease as best response. Progression of disease was present in 3 as the kind of best response, and disease response evaluation was not available in 6 patients. I think of some interest, 17 patients remained on treatment for more than 6 months, and 7 patients, they remained on treatment for more than 12 months with disease being controlled. And this is what we call a waterfall plot. It's kind of an early look at the size of the tumor and how it changed on therapy. In order to be scored as an objective tumor response, patients needed to have a decrease in the size of their tumor by 30% or more. And so you can see over on the right-hand side, there are 3 patients who had a decrease in their tumor size by more than 30%. So these are the patients that are called the partial responders. These other patients were classified as stable disease, but in many of the cases, there was a minor reduction in the tumor size. So we'll be taking a further look at this. So in summary, I think we can say that this clinical trial, P10015 or SARC-33, is one of the largest clinical trials, prospective clinical trials of chemotherapy in patients with advanced or metastatic EHE. We think that this trial will provide a very rich data set of patient data, lab results, tumor images, plasma samples, and tumor tissue for further study of EHE. And analysis of the study results are ongoing, and I hope to be able to share more of the results this summer at the ASCO annual meeting. I'd like to thank the many patients who volunteered to participate in this study and their families and friends that supported them through the study. Also the EHE Foundation for its support and referral of patients to the EHE Rare Cancer Charity for financial support for some of the correlative science work, and to Jane, who I think was one of the people that were the strongest advocates to bring Dr. Rubin and I together to develop and initiate this clinical trial. So thank you all.
All right, thank you as well. And I officially get to say that you're down south. I'm a Michigander, but from the UP, so you're a Southern resident to me.
Yeah, okay. Caught in the middle.
We've got a question about the rashes. Are they in specific locations? Are they all over? What are those looking like?
There are a number of different types of rashes that were reported. Some patients had more of an acneiform rash that occurred on the face and sometimes the chest. And we usually recommended treating that with a topical steroid as well as an antibiotic, either topical or oral. Some of the rashes were more of a diffuse rash throughout the whole body. And that type of a rash was a little bit harder to manage just because of the extent of skin involvement.
And now, if I'm correct, this drug is already FDA approved for melanoma. Is that right?
Correct. The drug was approved for the treatment of melanoma, usually in combination with what we call a BRAF inhibitor. It's not approved for treatment of patients with EHE or other sarcomas. And because of that, we needed to basically offer it through an investigational clinical trial for further understanding of patients, how it works in patients with EHE and whether or not there's any difference in safety between the patients with EHE and melanoma patients.
And related to that, since we have a documented track record on side effects from the melanoma trial, are you seeing any differences in the side effects with your EHE group compared to what we knew from melanoma?
We haven't taken a detailed look at that yet, but kind of on the surface, the first glance, it seems that this adverse effects, side effects that EHE patients are experiencing are pretty much in line with what we know from treating melanoma patients.
Got it. And then for the EHE patients you're treating in the trial, and then also, I guess this question would apply to potential future treatment if the results look good from the trial. Are there any differences in the way this is being administered to the EHE patients compared to melanoma in terms of dose, timing, anything like that?
The dose is not different and the timing's not different. I think the one major difference is that it's being administered by itself in patients with EHE, not in combination with a BRAF inhibitor. So with melanoma patients, they take two drugs together, a MEK inhibitor and a BRAF inhibitor, and there can be some additional adverse effects that are experienced because of that combination.
Got it. And then one last question. I know this is, you can use your clinical judgment on if and how you answer it, but with what you're seeing so far in the trials, what's your feel for what we're going to see as you collect more data and analyze the data?
Yeah, looking initially at the objective response rate, the number of partial responses, I think I was a little disappointed that it was as low as it is, that we're not seeing more patients who had an objective partial response. However, I think looking at the waterfall plot, sort of the last slide that I showed, the data looks more interesting because most patients had at least some reduction in the size of their tumors, which indicates that there could be more activity from the drug than we really were kind of seeing from the initial reports. Right now, we are just starting to look at the patient-reported questionnaire data. I'm very, very interested to see what that shows with respect to how the pain level changed once patients started taking the Trametinib. I heard anecdotally from a few sites that some patients had significant improvement of their pain once they started Trametinib. So we're looking to see if maybe even if we didn't really see a big reduction in the size of the EHE, if it really helped patients' symptoms from the EHE, and they were able to reduce the amount of narcotics they were taking and their pain was under much better control, that would be very encouraging. So we'll be taking a very close look at that over the next couple of months.
Well, and one more question related to the waterfall plot. We see the numbers going down slightly on quite a few of the patients, and we're basically comparing that to where they were before. Now, if these were patients that were not undergoing any treatment, do you have a feel for whether we would have been seeing a rise there? So difference from treatment to non-treatment obviously is not something you're measuring, but is there also a possibility that this is providing some stabilization that might be very interesting?
Yes, that's true. That's something we will be looking at. If you recall, in order to be eligible to participate in this trial, you had to have EHE that was either progressing, getting larger, or have the pain requiring treatment with narcotics. So I think there are many patients that enrolled who had actual progression of their EHE. We should have those MRI or CT scans that were done that showed that progression or enlargement in the EHE before starting therapy. So we can look at the rate of change prior to them going on drug, and then what happens once they start on the drug. And so we can look at that sort of difference in the trajectory of their disease, so to speak. So that'd be another very important aspect of this study to look at.
Excellent. Thank you so much for your time, and we're all going to be very curious to see how the study results come out. Look forward to hearing more from you in the future.
All right, great. Thank you so much for inviting me.
All right. Well, thank you so much, Dr. Schuetze. Just having a trial for such a rare cancer is a huge milestone, but what's even more impressive in my mind is just the number of patients enrolled and the collaboration being done with this trial and the data. I was actually a participant in the trial prior to having my transplant, so I want to just send a personal thank you as this trial was instrumental in my care. So thank you very much, Dr. Schuetze, for your time today and for the awesome information.